Okay, well, we are just getting started and people are going to be joining the Zoom session. So I'll just give it another few seconds before we officially get started. Okay, I think we could get started now. And certainly more people will be joining as the session proceeds. I am very, very excited to help kick off our first Global Health Grand Rounds of the year. And we have a very special speaker to do that. So we are introducing Dr. Mariam Fofana, who is an emergency medicine physician and an epidemiologist at the Yale University School of Public Health. And Dr. Fofana originally hails from Abidjan, Cote d'Ivoire, but where she still maintains close ties. She completed her undergraduate degree at Harvard, earned her MD and PhD in epidemiology from Johns Hopkins University, where she studied mathematical modeling and tuberculosis transmission and treatment. Dr. Fofana completed her emergency medicine training in the joint program of Massachusetts General Hospital and Brigham and Women's Hospital. So we are sort of welcoming her home with this talk. And she has since transitioned to the Yale School of Public Health. Her current work is centered in Brazil, where she investigates the determinants of SARS-CoV-2 transmission and immunity in urban settlements. And I'll say on a personal note, in addition to being an exceptional physician and scientist, Dr. Fofana has been a very close friend. She has a passion for bioethics, which she combines to make her a really thoughtful and inspiring educator and clinician and colleague. She's written and given presentations I've seen on dismantling racism and colonialism in global health and also in medical education. She's a role model for many. And I'm privileged to call her a friend since our days in medical school together. So we're very, very lucky and excited to have her kick off our Global Health Grand Rounds this year. So Dr. Fofana, take it away.
All right. Thank you very much, Dr. Moharad. Too kind of an introduction. But although I can't be with you all in person, it's kind of great to virtually be back on in a familiar place. As Dr. Moharad mentioned, I am an infectious disease epidemiologist and an emergency physician, which is a little bit of an odd combination, a story for another time. But more importantly, I'd say that my career and my personal interest really revolve around applying quantitative tools. So that includes statistical as well as mathematical models to understand the dynamics of infectious diseases, evaluate the impact of interventions, and all of that in the ultimate goal of promoting health equity, particularly among under-resourced and marginalized populations. And so that's going to be my goal in this presentation today. I am showing here the disclosure slide. I have no disclosures relevant to this particular presentation, and I will give everybody a couple of seconds to take note of the SMS code for attendance that is shown here. All right. So the work that I'm going to be discussing today is based on a long-standing collaboration between my current home institution, which is Yale University, the Instituto Gonçalo Muniz, which is the Salvador branch of the Osvaldo Cruz Foundation, or Fiocruz, which is the foremost health research institution in Brazil, and the Institute of Collective Health at the Universidade Federal da Bahia. And, I'm presenting today, but this work represents the combined efforts of a large, very large, and extremely dedicated team, some of whom are shown here. Today, I am fortunate to have a couple of my colleagues who will be also participating. So those are Nives and Neri and Feriolba, who I've circled on the picture here. And they're going to be able to share some of their insights and experiences working in this area, Pau da Lima. Pau da Lima, as I'm showing on the bottom picture here on the map, is an urban informal settlement, or as they're commonly known in Brazil, a favela, located in the city of Salvador, which is in the northeast of Brazil. And typical to similar settlements throughout the world, and in Brazil, it's very densely populated with poor access to sanitation and other services, and generally home to populations that are routinely marginalized in just about every aspect of society. And so it has been the site of a community-based open cohort that was initiated in 2002, primarily to evaluate and develop interventions for leptospirosis, which is highly prevalent in this area due to the lack of sanitation access and the presence of reservoirs such as rats. The cohort has been followed about annually to semi-annually with sociodemographic and serological surveys. And over time, the team has built an incredibly impressive research infrastructure and has been able to respond to the emergence or re-emergence of other infectious disease threats that are either driven or exacerbated by rapid urbanization and poverty. So these included, as I've shown here, the 2015 Zika outbreak that was associated with neonatal microcephaly. The team was also able to leverage this infrastructure that was built over 2 decades to respond to the emergence of chikungunya and most recently the emergence of SARS-CoV-2. So I was fortunate enough to join this fabulous team about 2 years ago in 2021. While they work on a variety of health problems, as I've shown in the previous slide, my work has been focused nearly exclusively on COVID-19. And the motivation and what I hope we've been able to achieve and will continue to achieve through this work is to understand the experience of the pandemic in this specific community, but also to gain broader and more generalizable scientific insights into the immune response to SARS-CoV-2. So the learning objectives for today are to understand the gradient of socioeconomic risk and socioeconomic and infection risk among residents of urban informal settlements, to describe the development of immune responses to SARS-CoV-2 over multiple sequential exposures to infection and vaccination, and to identify challenges and opportunities in promoting equity while conducting research in marginalized communities. I will note also on a personal level, this work has allowed me to shift my focus a little bit from the work that I did previously, which was pretty much entirely analytical on the modeling end of things, to get closer to the data and get closer really to the communities and the people who are at the center of the work. So in terms of the scope of what I will discuss today, I hope to shed some light on several key aspects of the complex relationship between immune response, socioeconomic factors, and the transmission of infection. So if we think about how all these factors are related, I think it's fairly straightforward that both your pre-existing immune status and socioeconomic factors may modulate an individual's risk of infection. Infection, in turn, drives immune responses. It can also have socioeconomic sequelae, whether that's as a direct result of infection, such as, for example, being unable to work or having to make large payments for medical care, or as downstream effects of widespread population-level transmission, including the reactions to high levels of transmission, such as social isolation or decreased economic activity. And finally, socioeconomic factors might affect immune response, for example, via disparate access to vaccination, as has been seen at micro and macro scales globally. So I will come back to this schematic as we go through the presentation and try to tease apart some of these effects. The data that I will be, on which the findings I'm presenting today are based, all come from these approximately semi-annual sociodemographic household-based surveys that have been conducted in the Pau de Lima community. So just about every 6 months to every year, a field team goes through the study area and performs a census of every household or every dwelling that is inhabited by people. Some dwellings are abandoned, others are used for commercial purposes. They perform a census of every individual in the household and identify eligible individuals whom we define here in our study as being 2 years of age or older and sleeping at least 3 nights per week within the study area. So for every individual, they will undergo an interview to assess some sociodemographic as well as medical data, and will also undergo collection of serum, saliva, and a nasal swab. The biological samples are then used to measure the level of antibodies using generally ELISA tests, as well as neutralization activity, whether with actual neutralization assays or pseudo-neutralization assays that are proxies for that neutralization activity. So the first question that I will try to address here today is, what are the drivers and gradients of risk within this community? I think everyone in the audience here will know that there are disparities in risk of developing COVID as well as in clinical outcomes once one has COVID-19 across socioeconomic strata. But even within a community that is itself largely disadvantaged, are there microgradients of risk? So we used the survey data from a little over 2,000 residents of Pau de Lima in 951 households. This is work that I co-led with Nivison. This is a pretty young population. 28% of our participants were children with a median age of 29. It is a predominantly female population, about 58%. And the vast majority of respondents identify as being of African descent, which in Brazilian Portuguese would be self-described as either Black or brown. It is a very poor population. The median per capita income is about just a little over $2, and suffers from high unemployment, with most adults, 51%, being unemployed, and most of those who are employed, 63%, working in the informal sector, with all of the instability that you can imagine comes with that. And so we first sought to assess how many people had experienced a SARS-CoV-2 infection. We conducted a first serological survey since the emergence of COVID-19 from November 2020 to February 2021. So the top panel here shows notifications in the city of Salvador. In the light gray, the confirmed cases, and in the dark gray, the deaths. And overlying that are blue lines indicating the time period of the survey. And what we found is that there was a quite surprisingly high attack rate after the first wave of the pandemic in Brazil. So we found that 48% of individuals at this time had antibodies against the spike protein. And this was prior to the availability of vaccines. And so those antibodies had to be reflective of a prior infection. For comparison, in other states, what was reported in the literature was about 10 to 30% seroprevalence. So certainly higher than was seen in other states, and in the city overall. We then wanted to look into, who was particularly at risk within this community. And what we found is that there was a higher seroprevalence among children, so those under 18, highlighted here in blue, among female participants, as well as those who were in the lowest strata of income, making less than $1.25 per day per capita. And all of those groups had greater than about 50 to 60% seroprevalence. Again, digging into what the underlying mechanisms might be here, we found that risk among children was mediated by larger household size. And so what I'm showing here is on the x-axis, the age groups, with the first set of bars showing children, those are under 18, and on the y-axis, how many residents are in a household, comparing people who did not have antibodies in gray and those who had antibodies reflective of infection in the purple or mauve. And what you can see here is that among the under 18 group, those who were positive for antibodies had larger household sizes, more residents in their households than those who were seronegative. And when we did a formal mediation analysis, we did find that the higher seroprevalence among children was indeed mediated by larger household size. And then when we look at the adults, what we find is that living with children was associated with a higher seroprevalence. So here I'm looking at different household compositions. So on the first household where there is a single adult with no children compared to a single adult with children, and then households with two adults and no children compared to households with two adults and children in the household. And in both cases, what we can see is that the presence of children in the household is associated with a higher seroprevalence among the adults in that household. And interestingly, we don't really see as much of a significant difference between men and women when we account for the difference in presence of children. And indeed, in this community, when we look at the household composition, showing the number of adults in a household on the x-axis and the number of children on the y-axis, and focusing on households that have one adult, we find that women who are the single adult in their households were much more likely to have children in their households than men were. And so that may have been a driver of the increased seroprevalence that we observed among women. And finally, we see that there is an interaction between gender and poverty, such that women who were unemployed and living in the lowest strata of income, again, less than $1.25 per day per capita, had significantly higher seroprevalence than their male counterparts who were similarly unemployed and in the same income stratum. And less of a difference when we were looking at individuals who were either employed or in higher income strata. So to sum this up, what we learned here is that there are structural risk factors, so household structure and poverty, that were key determinants of risk, at least during the first wave of the pandemic in this community. And the implication there, because these structural risk factors are not readily amenable to change, we can't easily or in the short term change somebody's household structure or change their income, depending on how imaginative we are. And so that demonstrates a need for interventions that are going to be less dependent on somebody's socioeconomic circumstances. In theory, vaccination could be such an intervention, could decrease risk across all socioeconomic strata, since biologically, the effects should be more or less equal. Now, of course, while the biological effect of vaccination may be independent of socioeconomic circumstances, the willingness and ability to get vaccinated are not, as we know. And so that brings me to our second major question. And this was to understand who is getting vaccinated or not in this community, and what barriers and gaps exist. This is work that was building on a prior study by another one of our colleagues, Pablo Aguilar-Ticona, who in that first survey that was conducted in November 2020 to February 21, again, prior to the widespread availability of vaccines, asked people whether they would be willing to get vaccinated if a vaccine were to become available. And among 985 adults who were surveyed at that time, 66% expressed that they were willing to get vaccinated. About 26% said that they would not want to get vaccinated, and then the remainder, about 8%, were unsure. And so in a subsequent survey that was conducted from November 2021, July to November 2021, rather. So after the availability of vaccines, we were able to follow 756 of those adults and ascertain their vaccination status and compare that to the vaccination intention that they had expressed earlier. One reason why we limited this to adults is that Brazil had age-based rollout of vaccination, so very few children and adolescents would have been eligible at the time that we conducted that survey. And of course, this is happening if we kind of, rewind a little bit to that time in the pandemic, at a time when there was much brouhaha and an argument was made that certain populations, particularly minority populations and those living in low and middle income countries, were going to have, exceeding very high levels of vaccine hesitancy. And those arguments were used to justify the lack of effort to ensure equitable access to vaccination. And indeed, what Pablo's work showed is that people actually did have comparable levels of intention to vaccinate, as we have seen in places such as the US. What was even more encouraging and surprising in the survey that we conducted afterwards was that not only was there high vaccination coverage overall, and what I'm showing here is that of those who said that they were willing to get vaccinated, the vast majority, 85%, did get vaccinated. But surprisingly, of those who said they were not willing to get vaccinated or they weren't sure, most of them ended up getting vaccinated. So 66% of people who had said they were not willing to get vaccinated still ended up getting vaccinated. And about 72% of those who were unsure did end up getting vaccinated. And I have hypotheses as to why that may be. We've tried to kind of dig into the data a little bit about whether this may have been related to, say, work-related vaccine mandates, et cetera. And one of our team members is doing some wonderful work with qualitative interviews to understand better people's attitudes to vaccination. So overall, we see there's high vaccination coverage in this community, even among those who had previously expressed some hesitancy. That being said, there were still some disparities. So this shows over time the vaccination coverage for at least one dose. The bottom line that you see is our cohort in Pau de Lima, and you can see that it achieved lower coverage of vaccination compared to the rest of the state of Bahia and Brazil overall. When we dig into some of the sociodemographic factors that are associated with vaccination behavior, we find that gender and education matter, although not necessarily in the way that we might have expected. So women were more likely to get vaccinated, about 83% versus 75%, which I think has been similar in many other settings. What was perhaps a bit surprising to me was that vaccination coverage was higher among people with fewer years of education. So those with six or fewer years of education got vaccinated about 85%, compared to 76% among those with 7 or more years of education. Other factors, however, such as employment or COVID-related beliefs and COVID history did not seem to be significant, at least not in the analysis that we conducted. So whether somebody was employed, whether they received government social assistance, was not statistically significantly associated with their vaccination status. And there was no significant difference among people based on how their perception of how serious COVID is, their perception of their own risk of getting COVID, or whether they themselves had a suspected or confirmed COVID diagnosis. And so in summary, what we find here in terms of how socioeconomic status affects vaccination intention and behavior is that there was quite high vaccine uptake in this community. That being said, there was a gender gap, and there were persistent disparities compared to uptake at the state and national level. So once people get vaccinated, the hope, of course, is that they develop antibodies that are going to be protective. And so the third question that I'm going to try to breach here is how antibody responses develop over multiple exposures to SARS-CoV-2 infection or vaccination, or the combination thereof. So in terms of the context here, we collected data from 137 participants from whom we had vaccination status, as well as serum, saliva, and nasal swabs. So I'm showing a couple of panels on the left here to give you a sense of the epidemic context at the time that we were collecting these samples. So again, we had a first survey that was conducted in November 2020 to February 21. This was after the first big wave of the epidemic. Brazil suffered a particularly devastating second wave that was associated with circulation of the Gamma variant, which circulated almost exclusively in South America. In contrast to other settings, though, there was relatively little circulation, relatively few cases, I should say, at the time that the Delta variant was circulating. And in the bottom panel, what you're seeing is the vaccination uptake in our cohort during that. And so as people were getting infected with different variants, whether the initial variants that were circulating, the gamma variant, and as they were getting vaccinated, we wanted to understand what is happening to their antibody responses. So I will show you first what we found from antibody responses in the serum, and that is basically, not unexpectedly, that serum neutralization activity increases with the number of exposures. So when we take these 137 people and we stratify them based on their exposure histories and going from left to right, essentially in increasing order of increasing intensity of exposure, so those who were vaccinated but had no evidence of infection, those who were infected had evidence of infection at the first survey, so after the first big wave, those who had evidence of infection at the second survey, those who were infected and then vaccinated, and those who were infected twice. And we can see that overall, people's antibody responses, and these are neutralizing responses against the ancestral Gamma, Delta, and Omicron variants, increase as they become vaccinated. From survey 1 to survey 2, increase as they become infected, increase as they become reinfected. What we can also see is that, again, roughly speaking, those who have had more exposure, so the group that got infected and then vaccinated, so has hybrid immunity, as well as the group that got infected twice, tend to have higher levels of responses, particularly against the Delta and Omicron variants, compared to those who have had just one exposure. When we look at the breadth of these antibody responses, and what I mean here is how are these antibodies able to target a broad array of epitopes and a broad array of antigenic targets, right? The antigenic targeting broadens as the population is exposed. And so this is an antigenic map that was generated from the 137 sera that I mentioned. And essentially what this is a way to depict how closely a person's and individuals' antibody responses are to a particular virus variant. So in the background, you'll see these are 95% confidence intervals for where the ancestral Gamma, Delta, and Omicron variants lie on this map. Every square is approximately a twofold decrease in neutralization ability. And then the sera that were collected in the first survey are shown in the blue squares, and the ones that were collected in the second survey are collected in the red squares, red circles. And so the big picture here is that we can see that the area covered on the map by the red circles, so it's the second survey, is larger than that covered by the blue squares. That being said, when we look at the area in the lower left corner where the Omicron variant is, there's barely any coverage there. So people had very little response to the Omicron variant, which again is consistent with what we observed, that there were very high incidence rates despite people having prior exposures. We then dug into what was happening in different tissue compartments. So looking at antibody responses across not only serum, but also in the mucosa. So I'm going to get a little bit in the weeds here. So I'd like to orient you first to this figure. So in trying to assess how people respond in the serum and in the mucosa, we used a hierarchical clustering algorithm to identify patterns of response in these three compartments. And so on the left, what you're seeing are the serum, nasal, and saliva responses. Each of the clusters that were identified by the quantitative algorithm are shown at the top. And the level of antibody expression is going to be shown as a heat map. So low expression in yellow, higher expression in the darker blue colors. And so what we see is that we identify 6 groups with different patterns of expression. And so there's a group here, for example, where there is generally low expression of antibodies in the serum as well as in the nasal and salivary compartments. And this group is composed primarily of people who were seronegative and had no evidence of infection. In contrast, we have a group here that has pretty high expression in all three compartments. And this group is composed primarily of people who have had infection and vaccination or two infections. And then there are these groups here of people who have particularly high expression in one compartment, whether that's in the saliva, in the group on the left, or in the nasal compartment for the group on the right. And so this has implications potentially for surveillance of exposures, at least at the time that we're really using serosurveillance, maybe less so now at this point in the epidemic. It has also implications for, what constitutes functional immunity against SARS-CoV-2 and its array of variants, and potentially implications for vaccine design and how we induce effective immune responses at various sites in the body. So what we learned here in broad strokes is that broader antigenic targeting, there's broader antigenic targeting over the course of the pandemic and with the rollout of vaccination, but that antibody responses may differ across tissue compartments. Hopefully that was not too overwhelming. I'm going to kind of zoom back out a little bit from this very biological discussion and go back to the socioeconomic sphere. And so having seen what is happening biologically and in terms of these gradients of risk within the community, the other question that we wanted to ask was, how did the pandemic affect people's socioeconomic circumstances? And specifically how schooling, employment, and food insecurity changed over the course of the pandemic. And also whether social assistance programs helped to mitigate those impacts. So here we followed longitudinally people who had participated in the cohort, not only during after the emergence of SARS-CoV-2, but people who had actually participated prior to the pandemic. So we had a pre-pandemic baseline, if you will, from a survey that was conducted in September to November 2019, and subsequently surveys during the pandemic from November 2020 to February 21, and then July to November 2021. Overall, this encompassed about 2,500 participants, of whom about 700 were followed at all three surveys. And what we find is, unfortunately, that among minors, participants who are under 18, school enrollment declined from about 92 to 94% pre-pandemic to 83 to 84% among girls and boys, respectively, at the second survey that we conducted post-pandemic. When we look at adults, we see, unfortunately, a similar trend when it comes to employment. There was significant loss of employment in this community, and it was particularly the case for women and informal workers. So on the left, it's essentially a survival curve, if you will, of people who started out employed prior to the pandemic and what happens to them over the course of these two surveys. And so on the left, we can see that both men and women about half of them lose employment over the course of the pandemic, but women are more likely to become unemployed during that time frame compared to men. And on the right, comparing those who are employed in a formal job versus those who work in the informal sector. And again, we see quite significant levels of employment loss, but more so among informal workers than formal workers. We also wanted to investigate what effect Brazil's social assistance programs may have had. So the majority of households in our community received some sort of cash transfer benefits. So these include Bolsa Familia, which is a program that existed for decades prior to the pandemic. It is a monthly conditional cash transfer targeting families that are living in poverty and gave somewhere around 32 to 38 Brazilian reais per child. It reached about 13 million families in 2019. And then Auxílio Emergencial, which was a COVID-specific relief mechanism that was targeting informal workers and those who were unemployed and had per capita income below a certain threshold, which was about 1,000 Brazilian reais. This was disbursed in about 3 payment cycles, and over the course of these 3 payment cycles, there was decreasing coverage, so fewer people were eligible, and the amount of benefit received also decreased over the course of these 3 cycles. So about 68 million people received benefits in the first cycle compared to about 39 million in the last cycle, and the benefits went from about 600 reais to 250 to 300. And so what we see is that about 34% of our participants or households received Bolsa Familia benefits pre-pandemic. That decreased slightly by the time of the second survey to 30%. Most participants were eligible for Auxílio Emergencial, at least in the first cycle of payments. So 64% received it in the first survey, but subsequently, as eligibility requirements were made more stringent, that declined to 41%. So when we then look at food insecurity within these households, first, let me know that food insecurity was highly prevalent. There was a slight decline overall from about 51% prior to the pandemic to 46% by the time that we conducted the second survey. However, this was not equally distributed among participants, recipients and non-recipients of cash transfer benefits. So when we look at households that did not receive any benefits, going from the pre-pandemic survey to the second survey conducted after the emergence of COVID-19, we see that there's rather an increasing trend in the proportion that are reporting food insecurity. However, when we look at households that received Auxílio Emergencial or both Bolsa Familia and Auxílio Emergencial, we see this interesting pattern of an initial decline of food insecurity and then a rebound at the time of survey 2. And that rebound coincides with the time that fewer people became eligible for the benefits and the amount of benefits was decreased. So, of course, we can't be certain about causal effects, but that certainly suggests that the cash transfers were helpful and that when they were withdrawn, there was a resurgence of food insecurity. So again, what we learned here, that this is a population with very high vulnerability to socioeconomic disruptions during the pandemic. Social assistance partially mitigated food insecurity, but it remained quite high, and that's demonstrative of considerable unmet needs that remain in this community. So, summing up this journey that we took through the immunologic and socioeconomic experience of the pandemic among this community in Pau de Lima, what we found overall is that there are multiple dimensions of antibody response that have to be considered. These include where the antibodies are being expressed in the body, the magnitude of expression of these antibodies, their neutralizing activity, as well as the breadth of antigenic targeting. We found that this population is highly vulnerable both to infection and to the socioeconomic sequelae of the pandemic, and that includes the sequelae of the control interventions. So you end up in kind of a double bind where you are at higher risk of getting COVID, but also at higher risk of suffering from the interventions that are implemented to control the spread of COVID. And we find finally that even in a population that compared to other communities is disadvantaged, there are within the community microgradients of risk generally associated with gender, income, and household structure. Some of you will know that I didn't quite address the last objective of that I had set out, which was to discuss how to conduct this research equitably, and that was intentional. I ended here with discussing the socioeconomic circumstances of this community because it raises really important questions about why and how we conduct research in such a community and uphold principles of equity as we do so. So rather than presenting data, my hope was that we can, as a group, have a thoughtful discussion on this topic as part of the question and answer session. And I'm very grateful to have two of my colleagues here who have far more experience than I do working in the Padalima community to contribute to this discussion. So before we move on to the question and answers, I'd just like to thank you all for your attention. And there are many, many, many people I need to thank for this work. Firstly, the residents of Padalima who have participated in the studies for 2 decades, have let our research teams into their homes year after year. The field team who do the very arduous work of walking through that neighborhood to collect these data. My mentors, Albert Coe at Yale University, Derek Cummings at the University of Florida, Federico Costa at Universidade Federal da Bahia. I'll also like to recognize my colleagues, Nivison Neri Jr., who is Dr. Nivison Neri Jr., who was who has been working in the Padalima community for, I believe, 15 or 16 years, and has been the data manager and really kind of spearheading the field operations for our studies, as well as Dr. Ferial Ba, who is a relatively newer addition to the team, but has kind of taken over a lot of the field operations, and who I believe are on the webinar, and so will be able to participate in the Q&A. And then finally, the sources of funding that have supported this work, including my funding from the ESTMH Burrs Wellcome Fellowship and the Yale Infectious Disease T32 program. So again, thank you all, and looking forward to our discussion.
Thank you. That was a wonderful, wonderful talk. Would you, do your colleagues want to say a word before we start the Q&A?
Yeah, I believe Nivison, if you wanted to.
Hi, excuse me. It's very congratulations, Mariam, for the presentation. It's wonderful. These are hard work for many years in the community. Is conduct a longer term course study like ours, spanning over 2 decades, present significant challenges, particularly in vulnerability areas. But our extensive presence in the community enable us to access our areas and conduct various diseases, laboratory tests. During the pandemic, we conduct crucial tests and offer guidance to participants. It's very important to work with our team in this area.
Thank you. Ferial, I don't know if you wanted to add something as well.
Excuse me. Ferial, could you help me, please?
Thank you for having me here. Very nice presentation from Mariam. And it's really nice to see the result of of that hard working, as Nilsson was saying. In even if we know that we want change from the worst to the better in that community, we hope that this work and our presence is changing something in the community, at least calling the authority, showing the situation, and also how can I say, inviting the community for the social participation, because even if Mariam didn't talk about that, now we have more and more people from the community who are how can I say, stand up for their right, if I can say that, like Bob Marley say. So it is, I think also that this part is really, really important. So that's all. Thank you.
Could I ask you a question? As part of being equitable is equal share of information. So clearly these are incredibly important findings that you have. How have you, or how would you suggest sharing findings within the community?
Yeah, I would say that's probably an area where we can do better. And I think that has perhaps fluctuated over time and kind of with the different issues that the research has addressed. I think with COVID, we're in a bit of an odd situation where, to some degree, the community's concerns have lessened over time, and so there may be less feeling of direct relevance of the work we're doing. We're still trying to provide some service to the community by, giving access to testing, etc. I know that one of the undergrads on our team, actually, wonderful, amazing, brilliant undergrad, Murilo, is really thinking hard about these questions of how to share our findings back to the community better, and really beyond test results of what is that are conducted during the data collection, and really trying to improve the community participation. I think there was stronger community participation in the past that has waned a little bit, and so we're trying to build that back up.
And to add my point of view to the Mariam speech, I will say that we are, after the pandemic, it is the situation has a little worsened in the community, mainly due to the violence. But we are having how do you say feira de saúde?
Feira de saúde.
We are having, let's say, a workshop. I don't know if it is a health workshop in the community where we are together with the social science people, professional. We are trying to communicate in a simple word our result to the community, because it is difficult. This presentation of Mariam, we can do it in the community, it will be very difficult to explain. So with the help of the social science professional from Instituto de Saúde Coletiva here in Salvador, we are trying to share this our result in the meaningful world, which will be more understand. They can understand better. We also have we are also working with the community, because currently we have a group present in the community in the Valley 1 who is working with them, and we are trying to do those feira de saúde according to their needs, because we are trying to adjust our research according to their needs. That is something which is really important.
Can I ask a follow-on question? How do you assess what are their needs? I think it's such a great point that this should be addressing the needs of the community. How do you suggest assessing that?
This part is led mainly by the social science group, which is trying. They are in the area for more than 1 year. They are trying to do it step by step, because due to the pandemic, due to the social situation, it's difficult to just show the scientific part, because sometimes they can feel that they can feel that they are not here by us. So due to it is necessary to do it step by step. So it is the social science group who is leading this part. So we are following the step. And for example, we thinking to do some action, but they tell us, no, let's do it little by little. So now we have some people from the community who are participating. Some of them are indeed doing, how can I say, master degree at Saudi at the public health school. So we are trying to give them also comment on dit parcours, give them the opportunity also to explain themselves. We have the social group who also is doing a mapping, trying to mapping the need in the community. They have, I don't know, it will be better someone from the area to talk about that. But what I can say, we know the need to take care about this aspect. So this is leading by a social science group in the community.
And those curves that Mariam showed with the decline in education and increased food insecurity and those very heartbreaking photos of the loss of the Kaplan Meier showing the loss of employment. Do you think those trends have reversed at all? Or do you feel like the economic loss that occurred with COVID, particularly for the informal workers, is it still as bad as it was, or do you think there's been any improvements?
I think that the context at that time was that can also be explained by the political context in Brazil. But currently we have I can say a movement, a positive movement in that sense. So now we have the government has tried to improve those Bolsa Familia. Actually, in the past, to have the Bolsa Familia, the person was obliged also to put the children at the school. What at that epoch, at that time, was not no era obligatory. It was not anymore obligatory due to the government at that moment. So I think also the situation has worsened due also to the political context, which has changed a lot in less than 1 year. So I think from now till the next year, I think this situation could change a little better because we have a political context which is favorable for health and for education. So I think that things are changing, also considering the political context.
Yeah. So just a little bit of background for those in the audience who may not know. So during the beginning of the pandemic, the president was Bolsonaro, who was essentially a COVID denialist and had tried to withdraw some of these social assistance programs or curtail them. And since October of last year, a new government is in place with Lula, who actually, I think, started the Bolsa Familia in his first term as president, and so has really tried to revive a lot of these social support programs. One thing that I'll say is that we can look at some of these aggregate trends of, how many children are enrolled in school, how many people are employed. What I worry about is that even if in the aggregate these trends reverse, these events of, getting unschooled or losing employment can really be life-altering and life-defining at the individual level. This is a context where it's easy to lose a job. It's very hard to gain another one. And so for this could really kind of change the trajectory of an individual's life quite significantly, even if we don't capture that at the population level.
So a follow-on question. These are, again, very heartbreaking results, especially in light of what you just said, that you see people's livelihoods disappear. And then also they're sort of vulnerable to politicians, really, and the way they view the world. What are your next steps going to be in your research in this community to address some of these incredibly important issues that you brought up? What do you see doing in the next couple of years as follow-up?
So there's a lot of work going on in the group and kind of in the different branches in the group. And some of that, again, is, the kind of broader scientific insights. And some of it is trying to, again, tie our work back to the community. Ferial, for example, is spearheading what I hope is going to be, very meaningful work looking at trends in mortality in the community and trying to understand, beyond COVID, what are all of the other factors that are affecting lives and livelihoods in this community. Violence is a huge factor, and that's violence within the community, violence from external forces such as the police. So there's definitely a lot of work to do, and I'm a very small part of all of that. So I daren't speak to all of the efforts that other people are putting in there, but we're trying to kind of work at multiple levels. For lack of a better term, kind of the purely scientific and also the social aspect. And some of that is, it's a compromise, right? Because we have to work within the political context, we have to work within also the funding context, right? So some of the things that we may want to do may not be as attractive to funders, and so we have to figure out a way to do a little bit of both and try to stay on the right side of that spectrum as much as possible.
Are there any other things that you feel like the audience should really know in terms of doing this work? And I think we're all doing global health work, but your points about equity are just very well taken. Do you have any last thoughts of pearls of wisdom for us as we're all doing this work across, where we're talking to people who live, they live such tenuous existences, and it's such a grave injustice. Do you have any last thoughts about what we should do?
I mean, I don't think I can speak with any authority on that. I think I am very much learning and trying to do better. I will say that one of the things that has really been touching for me working with this group and has really kind of kept me engaged is that we draw a lot of people in the group from the community itself. So lots of members of the field team live in the community, and we could not do our work without them. Just how familiar they are with the community and the context, how to navigate relationships with people. I would say, the thing that really, I don't want to say it shocks me, but it awes me truly that people have left us into their homes for 20 years, right? I think we owe them a huge, huge debt. I'm not sure that we're doing them justice quite yet, but we're trying.
Well, thank you. We are going to get shut off in a few seconds, so I don't want to ask you a question and then have the camera disappear. But I really wanted to thank all of you. This is such wonderful work you're doing, and thank you for bringing in the equity focus front and center in this work, and the community members who are sharing their life experiences and just the importance of their dignity, respects, and our responsibility to try to make their situation more fair.
Yeah, well, thank you all, and special thanks to Nivis and Ferial for being here virtually.
Thank you.
Thank you.
Thank you.
Thank you all.